it should appear. Okay, perfect. So welcome to the Echo series. I'm gonna just repeat some of the things that Christina had gone over, but we are really excited about using the Echo model as another strategy to have conversations about complicated cases and patients, and really look to bring our kind of obstetrical healthcare community together and thinking about how we can take care of our often higher risk patients, particularly really recognizing, I think this is a really great strategy for Iowa, for some of the providers and nurses who are working in our smaller facilities where there isn't as easy of access to subspecialty consultants. So here we go. So I think some of this, Christina already went over what our purpose is. Our topic selection, if you've looked at the flyer, which you probably did because that's probably how you got registered to be here, you saw that we have a topic for each session, and we chose those topics based on some of the key recommendations for the healthcare community from the Maternal Mortality Review Committee report that is coming out anytime now, very, very soon. And so we really looked at where did the committee recognize that there may have been opportunities to practice differently, either at like the clinical decision-making level of care of a patient or more of a healthcare system level where it seemed like, policies, procedures, practices needed to be different. So we tried to draw topics from there. And then most of our speakers that we've been able to recruit so far, we haven't filled the whole calendar yet, but we will, are members of the MMRC. So we really wanted to have this be one of the action strategies coming out of that. We are going to say this a lot of times. The entire purpose of an Echo series is case discussion. We're going to have these mini didactics with it, but it's really not intended to be like a webinar series where you could just kind of listen. It's really meant to be interactive and to also help you in your practice or on your unit in caring for patients experiencing more tricky situations. And so we got a nice number of case submissions ahead of this first one, and we are going to continue to ask for more cases. We don't yet know how long it will take us to talk about each case, so how many cases we need per month will be something that we'll kind of learn together. We have 4 that we could potentially discuss today, and I don't know if we'll get through all of them or not, but if not, that'll give us some already for next month. So as mentioned, there is continuing education available, and you have up to 2 weeks, I believe, to kind of complete the little survey, and then you'll get your continuing education credit. Just worth noting that the Iowa Medical Society did receive some pilot funding to help get this going so that we can use the Echo platform, and that is through a program called UCare. Talking a little bit more about cases, I would imagine that some in the audience have either participated in an Echo before or have some familiarity with the Echo model. It is really robustly used in the primary care spaces. And so I want to talk about how we're thinking we can apply this in a maternal health space. So on the left-hand side, advice on a current patient is really, I think, how this is commonly used in a primary care space where somebody may come forward, here's a patient that I've been taking care of in my practice, not quite sure what to do next for them, and you have an opportunity to get information and advice from a subspecialist. And so that approach can absolutely work really well. So this might be a patient that is receiving, coming in for preconception care, prenatal care, postpartum care. Maybe they have a complicated condition. I think particularly for some of our rural providers, perhaps somebody who you may not be able to get in to see a subspecialist in a timely manner, especially if we have the cases ahead of time. We can, I'm a general OB/GYN. I'm not going to have the answer to everybody's questions, but we can make sure that we have the right subspecialist on to help provide some advice. I think what we saw in the case submissions is I think what is going to feel more familiar when we think about reviewing obstetrical cases is we know a lot of times the complications with an obstetric patient are going to arise during their hospitalization when they give birth. And it is not going to be feasible to like have an echo session in the midst of while you're providing care to somebody who's in labor, right? And so this may be where we see more cases come in, and it's a little bit of a different approach than I think is traditional in an echo series, but I do think it can still work and offer a lot of value, which is if you have some sort of a complicated patient or event, and perhaps this has all already happened, and you just kind of like a different opinion, somebody else to look at it and kind of do a review of the clinical care provided. It's important to note that that approach would be really thinking through a systems lens. So this isn't something where we're going to say, well, here's what so and so did wrong, right? I think it's really thinking more about a systems approach to care. Um, and and in that, I would say that for many of you have probably participated when the statewide perinatal program comes to your hospital. One thing I forgot to add to my bio, because it's relatively new, is I am now the OB physician with that program. And so I would hope that people would feel like it was similar to when we come and we are reviewing cases. And again, our goal is to identify opportunities for improvement, not to look to place blame on any individual or facility for an outcome. It is important to know that this is a protected review in our best ability to protect it. And some of that depends on you partnering with us in that protection. So when you submit your cases, it should be de-identified of anything that would be, allow that patient to be recognized. If it is not terribly relevant exactly how old the patient is or all of their obstetrical history, you can even change that so that it's really, you keep the essence of what's important to talk about the case, but maybe change other factors. In the cases that were submitted, we did receive permission to share the facility that they happened at if it is pertinent to the conversation. I did redact, like if you say I transferred my patient to UIHC, I'm probably going to just redact UIHC from that. I transfer the patient to a higher level of care. So I just want everybody to feel really safe that you can talk about cases here. We are not going to record the case discussions. And so the only way to hear them is to attend live. And that is just to make sure that we don't create a world in which a conversation about a case lives out on the wilds of the internet. So if you submit a case and you would like to hear about it, you do need to attend the session where we talked about it. And so we can, if we have the like joy of having an influx of cases, we will then try to let you know which month we've got your case on for if you're not sure you can come every month. Ideally, we'll try to align the topics to the expert panel. So for example, if we get some mental health cases, we're probably going to hold them till this summer when we have Dr. Lundquist and others speaking about maternal mental health, because I'd really like her to lead the discussion on those cases. Any questions about the cases, the submission process, or the case conversations? Okay. So you'll see this a lot, but here's the QR code that will take you to the case submission. I'll put it up again at the end, but I thought it might be here. Just you might want to pull it up if you find as we're going through today's session that you're thinking about a case that you've maybe had recently at your facility. You might want to think about submitting it. Okay, here's our list. I'm not going to read it to you. Today, I am going to do a little overview on the key findings from our Maternal Mortality Review Committee. And then moving forward, each month we'll have a more clinically specific topic. But today is kind of just an overview of what are the key recommendations towards the healthcare community from the MMRC. Okay, so talking about maternal mortality here in Iowa. So I always like to just do a little bit of terminology review when I talk about maternal mortality because I think there's a lot of press, like outside of the medical spaces on maternal deaths, which is a good thing. This is what allows there to be more attention and more funding towards addressing these issues. But it can lead to a lot of terms being thrown around. So when we think about deaths that happen in the context of pregnancy, the largest umbrella is to think about pregnancy-associated mortality. And this is the death of somebody who is currently pregnant or has been pregnant within the past year. The pregnancy could have had any ending, could have been a miscarriage 10 months ago, and the death could have had everything or nothing to do with the pregnancy. So this is just in time, anybody who has died related to pregnancy. Pregnancy-related mortality is among those people, those that we think that their death had to do with the fact that they were pregnant, either very directly, like they died of an obstetric hemorrhage, or indirectly, in that maybe they had cancer and their cancer care was different because they were pregnant and they, maybe declined to receive chemotherapy or something, and then they died as a result of their disease. And then within that, pregnancy-related mortality, which is still up to a year postpartum, is the term maternal mortality, which actually has an official definition from the World Health Organization. And it is deaths that are during pregnancy or up to 42 days postpartum that are related to the pregnancy. And so maternal mortality is the term that is commonly used, but it's actually an official term, and this is how countries are compared. And so when you see US statistics, which are largely your pregnancy-related mortality, you can't compare those numbers to maternal mortality ratios from other countries because you're looking at different metrics. Okay. So the purpose of the MMRC, this is a multidisciplinary committee, includes healthcare, all the different specialties you could imagine, nursing, public health, social work. We recently brought in law enforcement, so it's a very diverse committee. And we have a couple of objectives when we do a review. Our first question that we need to be able to answer is, do we think that the death was pregnancy related or not? And then we want to assess if we think there was any degree of preventability. And it's not a binary. We don't say yes, preventable, no preventable. Within the preventable, we have a chance to say, do we think this is very likely it could have been prevented or only like slightly likely? But then all of those will then fall into the category we thought there was at least some chance to alter the outcome. And then where we really spend a lot of our time is talking about recommendations from this case. Like, what do we think needed to be different for this case to have a different outcome? And that is at a lot of different levels, all the way out to the community level and even the policy level. We have a standard review process and a form from the CDC, and there's a lot more detail on that, but for the sake of time today, I'm not going to go into it, but all of this information should be available on the internet. I know the CDC's website has been in flux recently, but if anybody's interested in knowing more about this, I'm happy to provide them with a copy of the form. So there were 20 pregnancy-related deaths in the 3-year time period of 2019 to 2021 in our state. That's not all of the pregnancy-associated deaths, but among all the deaths that occurred in that time period, we determined that 20 of those were pregnancy-related deaths. And so this gives us a higher pregnancy-related maternal mortality than we had previously had, almost double. However, COVID and infection, but COVID was the leading cause of death. If you removed the COVID cases, we did still have an increase in pregnancy-related mortality in our state during that time, although it was not a doubling. The vast majority of deaths in our state that are pregnancy-related are happening after birth, 80%. And 95% of the cases, which you can do the math there, 19 of the 20 cases, we felt that the death was at least possibly preventable. We consider if different factors may have contributed to a death, and I just thought I'd highlight that we did feel that obesity contributed to approximately 40% of the deaths, and that doesn't necessarily mean that just the person had a BMI over 30. It was that we actually felt that the health factors associated with the size of their body directly contributed to their death. So I'm going to go through recommendations for obstetrical healthcare providers, and then I'm going to go through recommendations for hospitals. And I'm choosing to present only the top recommendations that came up on multiple cases. There are many, many more recommendations that you can read in the full report, which I hope that you will once we get it released. So one of our biggest recommendations, the number one recommendation for obstetrical healthcare providers, physicians, nurses, midwives, anesthesiologists, is that we need to really pay attention to our national standards of care and make sure that every hospital is following the national standards of care and that every provider and nurse within those facilities are following the national standards of care. There were cases where there was clear deviation from national guidelines that are available largely through ACOG and the Alliance for Innovation in Maternal Health, which is ACOG's quality improvement program, where we did not see the standard of care in how to evaluate and manage prenatal anemia, evaluate and manage hypertensive disorders of pregnancy, and how to evaluate and manage obstetric hemorrhage. The next main recommendation for obstetrical providers is recognizing mental health conditions that may be affecting a perinatal population. And so our specific recommendation is that we should be universally screening all of our patients for mood disorders at multiple times during the pregnancy using a validated screening instrument, which could be your PHQ-9, it could be your EPDS. Those would be two for mood disorders. The GAD-7 for anxiety is a good screener. And we should be providing evidence-based treatment for mood disorders, including pharmacologic therapy and referral for counseling. Now, we know that mental health care services are limited in much of our state, but there were numerous cases where people were actually taken off of their mental health medications in pregnancy, seemingly at the advice of healthcare providers, as well as instances where it did not appear that people had received standard screening, and mental health, their current state of mental health was thought to have contributed to their death. Next is that we recommend that obstetrical providers and staff should be providing person-centered communication that is inclusive of patient-specific needs. And that includes recognizing cultural, religious, and social influences that may impact people's decision-makings. Ideally, we should be engaging in shared decision-making when developing care plans for patients that incorporates their values and beliefs so that they feel included in the care process. And we should be recognizing how unconscious bias, including things like weight stigma, may influence our interactions with our patients. Okay, I think there's 4 recommendations for healthcare facilities. You're going to see that some of these are very similar. So same recommendation on the facility side, that facilities should really ensure that everybody receiving care in their facility is receiving respectful person-centered care. Facility strategies for this include making sure that written materials and screening tools that you're using are able to be administered in somebody's preferred language. That you're identifying policies, procedures, maybe tools within your electronic health record that may have ingrained stigma or perpetuate racial bias. And make sure that you are offering your staff training, right? The providers can't do what I said on the slide before, the providers and nurses, if they don't have access to that sort of training. And so thinking about, are we ensuring that our teams really understand effective listening skills, particularly when working with people with marginalized backgrounds or may have adverse childhood experiences or other things that result in them having more challenges showing up in the healthcare system and feeling unheard when they're working with healthcare providers. Facilities should have a comprehensive hemorrhage prevention and management guideline that includes hemorrhage risk assessment, real-time quantification and accumulation of blood loss, a stage-based hemorrhage management plan, and a massive transfusion protocol. Facilities who do not have a large enough blood bank to have an MTP should have, or to run an MTP off of their own blood bank, should have a protocol that outlines exactly how they would acquire additional blood products from other sources. And so lots of resources nationally on this. We worked on this together through the obstetric hemorrhage bundle. However, unfortunately, we still are seeing opportunities to recognize the degree of hemorrhage that somebody is in and intervene appropriately with life-saving interventions in some cases. Facilities should also have a protocol for venous thromboembolism, risk assessment, and then risk-based prophylaxis. Individuals who are recognized to be at high risk of having a DVT or a PE antenatally should have this really clearly documented in their hospital record so that everybody taking care of them is aware of their risk factors. Especially in places where outpatient clinics may use a different electronic health record system than the hospital where somebody would give birth. This is the type of information that we would want to make sure is clearly available to everybody caring for the individual. There is not currently like an AIM bundle on VTE, nor is it really concisely outlined by ACOG anywhere, but the CMQCC toolkit, which has been around for quite some time, is a really nice resource, and it is available to anybody from their website. You just have to register with their website to download this, and the registration is free. I think it's just how they track, who's using their resources, and this is an evidence-based toolkit because they used California maternal deaths to kind of figure out a risk assessment tool. Okay. Um, Before we move into cases for the rest of the session, does anybody have any questions about the MMRC report, or anything that I shared? Okay, going once, going